Welcome to the On Your Mind podcast, where we are changing the mental health narrative, bringing hope and solutions. Here's your host, Timothy J. Hayes, psychologist.
Ross Ellenhorn, Ph.D., is an eminent thought leader on innovative methods and programs which are aimed at helping individuals who have been diagnosed with psychiatric and substance use issues and helping them recover in their own communities instead of in hospital or residential settings. Well, Dr. Ellenhorn, thank you for joining me today.
Yes, it's really great to be here. Yeah.
I'm hoping you could get us started by telling us a little bit about how you got into the work you do and what drives your passion for it.
I mean, there's all kinds of reasons, just like anybody, why I got into this work. I consider what I do as really kind of like serious social work about how to help people recover socially who have been diagnosed as having psychiatric issues, and what happens to them socially because of that, and how often that is even more harmful than the actual diagnosis. And I'm guessing that comes out of my own experiences of my own stigma as a kid who was diagnosed as having a severe learning disability at around age 12, and what that label meant to me, the thing that had the most effect on my functioning, not whatever disability there was. I could tell you that, with a PhD and 3 books under my belt, that I'm not even sure there was a disability. There was probably inability to factory learn.
Yes.
So that has stuck with me all my life. And so the programs I build and I think about are always about not ignoring that there's something going on for a person psychiatrically, but recognizing how powerfully important it is to think of them as social beings. And so that probably is what brought me to this,
Right. To put it in the context.
Yeah.
Instead of just trying to isolate it and treat, a symptom rather than dealing with a person.
Yeah. When you talk about the brain, you're talking about a social organ. You're talking about probably the most profound social organ on earth. I mean, some animals collaborate, some animals invent, crows invent, whales invent. Not a lot of animals collaborate to invent. And so that's just a central element of us, is how do we interact with each other and who are we with other people? And so much of our days are affected by who am I to you, who are you to me? And when it comes to psychiatric issues, we start ignoring that. We start talking about the person as just sort of an isolated problem. And I think that doesn't work. And worse yet, I think it's harmful to people. And so that's sort of mostly what I do. There's other areas we could talk about later that aren't about that, but yeah.
Well, so part of what I heard you say is that it's what that label meant to you that was the most devastating part of it. Is that what you intended to say? Or is it that the stigma that other people brought to you because of the label?
I think the label is stigmatizing, I mean, the amazing thing we do in our culture is we claim that by calling people broken and not amoral, we're no longer stigmatizing them. It's insane. It's a brain disease, so you can't stigmatize them is an insane thing to say. By the way, my PhD is in sociology. For a sociologist, it makes no sense to us because stigma is about kicking out anybody who's diseased from your group.
Right.
And so the idea that there's something kind of neutral about a diagnosis, instead of that's the number one stigma. If you're somebody with a psychiatric issue, the number one stigma in your life, the person who stigmatized you first is probably your psychiatrist. It's not somebody on the street. Most people don't even know you have a mental illness. It's that constant message that you're broken. You could translate directly mental illness. You change those words to sick in the head. So we're basically walking around saying that person's sick in the head, which is a stigmatizing label, And so how do we kind of help? But how do we help people actually with their suffering, their cornucopia of different sufferings that are in the DSM? How do we help them still with those things without getting in the process of talking about them as broken? And how do we provide treatments that don't treat them as if they're broken? Treatments that say we have the right tool for that kind of brokenness, right? And this kind of promise that if you go to this place or that place, they have the thing that'll fix your brokenness. And so get assessed first, and then after the assessment, someone will know the exact technique that'll help you out of it. That kind of world is causes a lot of problem for people. you
Well,
know?
and as you talk about the most common pattern these days is when somebody has a difficulty, they go to their doctor and or they end up in front of a psychiatrist and or they end up in a hospital or an outpatient intensive
Hmm.
outpatient program until such time as they've been assessed to have fewer of the symptoms.
Yeah,
And then they're allowed to go back to their families and their home and their community. And
yeah.
that the model you've put together, which tries to short circuit that and treat people in the context of their home or family or community
Hmm.
and help them with their difficulties concomitant to helping them stay integrated or reintegrated for
Hmm.
whatever
Yeah.
you know happened in their symptoms package had them isolate from their family or
Hmm.
community.
Yeah.
Well, how do you do that? How does that
Hmm.
how does Ellenhorn as a community make that happen or help people make that happen for themselves?
Yeah. Yeah. Well, first of all, I just want to comment on what you're saying that we live within systems that basically say that the job of the professionals is to reduce symptoms and that symptom reduction is the job. I think a person feeling alive and authentic and connected to the world is the job. And symptoms can get in the way of that. And so we want to get rid of the symptoms so that they can get to that. But if I had the choice for someone in my program between someone who hears voices and is married and has a great social life and a great job compared to someone who doesn't hear voices and is completely blotted out by their medications, tranquilized by their medications, I'd pick the first one. If I had the choice between someone who's moderating their drinking, but has a good life and a meaningful life compared to someone who's living in hell because they're in complete absence, I pick the first one. So part of what we do in our program is always begin with the idea of where exactly do you want to go? What is the thing that you want to change in your life that's going to give your life greater meaning and purpose? Not let's get rid of the symptoms. Then we have the discussion about the symptoms. You know as well as I that our field has this idea that the chief complaint, the thing that the client says they need, it's all but ignored in our field. Rarely does a client come to my program and say, I've got bipolar disorder and I want treatment for it. What they say is, my friends moved ahead. They have lives of their own. They're doing really well in life. And I never made it. And I feel horrible about myself in comparison to them. That's their chief complaint. So why don't we work on that chief complaint and then have a conversations about symptoms on the way? 80% of what we do is outside the office, 70, 80%. So we're really trying to help people kind of go back to work, go back to school, simply keep their apartments nice, do whatever it takes to help them kind of rebuild a sense of pride and connectedness to the world, right? And that pride is the number one thing. Some sense I can actually make it in life because they've lost a sense of what's called self-efficacy, self-belief, a belief in themselves. And so building that pride is kind of one of the central things we're doing. Now, to do that, you need a hospital without walls because we deal with highly complex cases. So you need a psychiatrist there every morning, meeting with the team, talking about the last 24 hours. We do rounds every single morning, like in a hospital. And you need a whole team of professionals helping that person because you're trying to get them ready before other people would think they're ready. You know, programs have this idea of readiness. You can't go back to school until you're ready. You can't have a romantic relationship when you're ready. You can't go back to work until you're ready. If social inclusion is medicine, what those programs are saying is you can't have the
Have your
medicine until
medicine
you're
until you're
well.
better. Yep.
Right.
Yeah.
And so we're trying to get you the medicine now, but that takes a lot of a team around you to make it happen because a lot's going on for you psychiatrically too. So that's the basic idea is how do we help you step by step rebuild yourself? Because our clients are really terrified of trying again. And I could tell you more about that later, but we have a whole theory called fear of hope. It's just
Right.
my
I was going to
main
say
research
that
is on that. Yeah, yeah,
that you've
yeah,
actually done research on the fear of hope and how,
yeah,
hope's an okay thing for motivating people, but it isn't the only factor. And if there's a
yeah,
high fear of hope, you can have
yeah.
a high hope and a high fear of hope, and you actually plan less for the future than people who have moderate hope.
That's right. Yeah, that's right. That's exactly right. That the fear of hope, hope is the mindset. It's the main mindset built for getting you through uncertainty to something you want. That's what it is. And it is the mindset for that.
Getting you through
And
uncertainty towards something you want.
Right, which is opposite. It's not really optimism, sort of this cheap emotion. It's like everything is going to be great. That's not hope. Hope, you think about, the greatest philosopher on hope was probably in my mind Martin Luther King, and he wasn't ever talking about everything's going to be great. He was talking about how do we keep going through uncertainty to get where we want to go. The getting through it was the point, to something. And that also means that as you go along, the thing you're hoping for becomes this sort of important thing to you. It's more important than if you didn't hope for it. And when you don't get it, you feel helpless. I didn't get my needs met. The world is not as benign as I thought. I'm not as strong as I thought. And that disappointment can be really powerfully damaging, especially for psychiatric patients, because they're constantly, first of all, their job is to change. It's an odd thing, right? Every morning you wake up and your job is everybody's watching and saying, did you change? Is today the day you change? How much did you change? Is that really change? You're constantly under this expectation area. And so they're always about, how do I manage the expectations of all these people about me, around me? And one way to manage them is to stay the same, is to not change, not raise hopes, not raise their own hopes. And so they get stuck in this place where they're just terrified of hope again. Hope becomes the central element in their lives that's scaring them. And you said something very accurate, that what we found in the research is that kind of bolsters this idea of the fear of hope, is that people that rate high on a fear of hope scale and rate high on a hope scale are the most agitated of the people we work with. It's like standing on a cliff with a friend, and the friend jumps off that cliff all the time into the ocean. You're terrified of doing it, and they're pushing you to do it. That's what a therapist is like for you. That's why we call that resistance, but it's actually fear of hope. I don't want to do that. I don't want to hope again, And I think that that's a central element in our clients' lives. It's a big part of what's going on for people who have been in and out of treatment.
So you said that about 80% of what you do with people is outside of the office.
Mm-hmm.
Can you give us some idea of what that is?
It can be almost anything, but it should be something that's about slowly but surely raising a person's sense of efficacy, self-efficacy. So it can be as simple as, and now all our staff are master's level clinicians. So these are not companions, or like there's a lot of companions out there in the mental health field. A lot of coaches, they're not coaches. They're using all kinds of therapeutic techniques, but they might be using those to go grocery shopping, to have conversations with the person about what's going on for them in that moment, or paying bills, or going to a yoga class, or taking a class with somebody, or preparing the person to get ready for class, or picking them up after class. All those sorts of things are going on. And in the meantime, they might also be we have some techniques or some forms of therapy that we've curated in our program, where we've been sort of trained in. They might be doing some of those things too on the fly with the person. So it's a multitude of things. What I think is a good example, a client in our program that really severe anxiety issues, also had an alcohol problem, didn't tell us he was drinking, then told us, which is probably a testament to the fact that we're a harm reduction program. We don't kick people out if they're using. So he had to go to detox, or he'd be in danger if he wanted to quit. So he went to detox. Detox recommended that he go to a partial hospitalization program and all kinds of programs during the day. And the problem was he was in school and about to finish up. That would have destroyed him.
Yeah.
So what we did is we drove him to school each day. We met him during his lunch breaks. We kept having conversations with him that were kind of motivational interviewing, but based, really kind of empathic conversations. We picked him up at the end of the day. We worked with him to be tested. We don't always test people for use. And it was a 24-hour hospital without walls to get that guy his degree. And it was all about this. How do we keep you going? Because that's the medicine. We want to get you to that medicine. But we've gone to concerts with people. We've done anything that a person is sort of afraid of or hasn't done recently. We don't consider that exposure therapy. We don't consider it skills therapy. We consider it faith in oneself therapy. You can't.
Yeah, go ahead. At one point you talked about social inclusion as a medicine.
Yeah.
That's hitting home.
Yeah. Well, there's a couple of reasons why it is. I mean, first of all, there's just a lot of evidence that we're unwell when we're not connected. I mean, there's just so much evidence. The whole loneliness epidemic is proving it, that it ties with smoking and heart and cholesterol for heart disease, right? So it's sort of proven that isolation and not being connected is bad for your health, is bad for you psychologically, causes all kinds of problems. But there's another area, which is a person's ability to accept help, to actually go to therapy and use it, depends on what's happening to them socially. And I'll explain why in a second, but I just want to say we take that for granted, that there are clients who are in denial or resistance without recognizing that what we're calling denial and resistance might be because they don't have enough social resources. And we're blaming it for them. And by the way, we have all these outpatient programs that claim they do great work on all these diagnoses. They do great work on diagnoses on people who can actually come to an outpatient program every day. That's someone who's has mild psychiatric symptoms. And the rest of them, we're saying they're in denial, they're in resistance, they're difficult to engage, forget them. So the people who have the worst problems are the ones that are going in the hospital and then not able to be in outpatient treatment. And we're the ones that are trying to get out to those people. Okay, so there's a concept in social psychology called threat assessment. And it's a very simple model, but it's a very accurate model. And it says that if something is challenging in front of you and you don't have the resources to meet that challenge, that's a threat. So if you're walking along in your shorts and a t-shirt and it starts to snow, you feel threat. If you're able to find some ski pants and a jacket, it becomes a challenge. Social resources, like a sense of social support, a sense of self-efficacy, a sense of social inclusion, a sense of purpose. These are all measurable things within social psychology, sense of purpose and meaning in your life. Those are all like that coat. If you don't have those things, everything looks like a threat, including looking at yourself, looking at your problems, dealing with the fact that you might have a psychiatric issue, having to meet with a therapist. Everything feels threatening in that. Those are major challenges in all our lives. And so this thing we're calling resistance and we're calling denial, I think is because the person doesn't have enough resources around them for them to do it. They're afraid of doing it. They're too afraid of doing it because it feels so threatening. And so that's where it's a medicine too. It's a medicine that gets you to the medicine. It's a way of putting that coat around the person so that they feel strong enough to meet the challenge of looking at their issues.
And a lot of times people may have the resources, but they don't feel like they do. So there's that social network that can give them the feedback to say, oh yeah, you are enough, you can do it. Without that feedback, the isolation, as you're talking about, it really weakens. I keep thinking about, the failure to thrive in infants that aren't getting, that comfort and care. Well, here at the other end of our life as adulthood, the isolation does the same thing. It starts to weaken us and, allow for all kinds of distortion in perception that isn't productive.
Yeah. I mean, you're getting me wanting to talk about, I'm going to talk about it really quickly. I think that when we talk about people that are having problems with attachment and attachment trauma, I'm never going to write about this because it'll be too hard, too difficult to write about. I think it's hope trauma. I think that every time an infant is reaching to their parent, what they're doing is they're reaching for something that they're yearned for through uncertainty. And the repeated disappointments of that is what we're calling attachment trauma. It's I'm not going to hope again. And that kid, the failure to thrive kid, that kid that turns their head and doesn't take, that person is because of disappointment. There's a fascinating and completely tragic thing that was going on in I think Denmark called resignation syndrome. And it was these Syrian kids when everybody left Syria and their parents would go for citizenship and get rejected. And the kids were doing fine. But when the parents had to go a second time, the kids would fall asleep and they'd stay asleep for a year. They could be fed, people could take care of them, but they were asleep for a year until something shifted in whether they were staying or not. And they could kind of feel it through their parents. So wow. that kid is just like, I'm removing myself from the world. I can't hope again. I can't get excited about this. It can't happen. and it's called resignation syndrome. And so that's sort of central element to me in our attachments is this issue of hope. But you're saying something else that's really interesting to me, and I'm really very sure of it, that where we're most injured often is in our capacity to accept help. Our capacity, there might be a social network around us, like you're saying, but if we can't take it in, the event doesn't happen. You can't talk about holding another unless the person feels held. You
Right.
can't talk about care without the person feeling cared. You can do the best job possible, but the caring event doesn't happen if the person isn't experiencing it. And you're absolutely right that loneliness ends up injuring people in that way, where they can no longer, even when they're around them, they can no longer come back because they're so hurt in that ability to take things in,
Yeah.
you
Just
know?
let it in. Right. And
Yeah,
they just won't.
they won't. Right, right. For what, maybe because of these issues of disappointment or whatever it is, but that's exactly right. And in a way, we can even think about everything we're doing with our clients is about finding a way towards getting our care to them. That it's really is this kind of process of how do I get the care to you? And their pain and their suffering is often because not because they're isolated, but because they can't metabolize it. They can't bring it in.
Yeah. Yeah. They can't let it in. It just feels too threatening. You're talking about threat, right? And it feels like a threat.
Yeah, 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 yeah,
I
yeah.
remember
Yeah.
there's some tremendous work that was done years ago that it was too controversial, and people, we have our cultural norms, and if it pushes too hard against the cultural norms, it doesn't get accepted. But people were
Mm-hmm.
talking about how when young people had too much rejection at a young enough age. In other words, their hopes were dashed when they
Mm-hmm.
reached for love or comfort or
Yeah.
safety, then they would harden, and they would talk about
Mm-hmm.
how they would hide their emotional state or their capacity for love,
Yeah.
even from themselves. And so
Yeah.
if they were got to be a preteen or teen, and they ended up in a loving foster home or in a nice program where there's lots of nurturance and care, they just can't let it in. And it literally
Mm.
feels painful for them to be in the presence of somebody who's lovingly caring for them. And,
Yeah.
and
Yeah.
they would work on these rather dramatic new programs to say, well, we're going to love you even if you're kicking and screaming, and we're going to wrap you up and hold you.
Yeah.
And that was just, it was too harsh. I mean, the pushback from the individual against the threat of letting
Yeah.
love in or letting compassion
Yeah.
in or letting safety in could end up in all kinds of violence for a long period of time before they would finally get the idea that the other person wasn't going away, that they weren't going to be rejected. And of course,
Yeah.
some people never let that in, but
Yeah. I mean, it's both. To me, it's both about the fear that if you let the person in, they'll then reject you, and it's also the fear of if I let this in, is it poison? You know, if I let this, because they learned at a young age, I let that parent in, and who I let in.
yeah,
And so it's like I don't want to suckle because there could be poison in that milk,
right.
And it's also that. And you know, on my 60th birthday, my wife put together just this wonderful birthday party for me. It was just the kids and our grandchild. That's it, you know. And went to a great restaurant, came back and had cake. Everybody went to bed, and I thought that was that was a really nice party. I'm so glad I was invited. I had forgotten I thought I was a guest, not the guest of honor. So I've got that in me. The inability to see when there's affection around me and people are feeling things towards me. I have that. I know what that is, you know?
Shields up, shields at 70%. Yeah.
Yeah, and so I think we all have areas where we can't quite, it's such a sin in a way, you know, when somebody's caring for you and you can't feel it. There's almost something ethical about if someone's giving you a gift, you should take it, you know? And yeah, I've got that in my life. I do. Yeah.
Well, there's the echo of so many people I work with who had parents that were either deeply wounded or who just missed them and
Mm-hmm.
what their individual needs were, and
Mm-hmm.
they weren't getting met. So that as whether they're young adults or full-fledged adults, they are terrified of letting in compliments or accepting their own success and thriving, because that to them seems like becoming the grandiose person that was their parent, or
Yeah.
whatever image they had
Yeah.
of their parent.
Yeah.
And so
Yeah.
they have all kinds of accomplishments that they cannot acknowledge, or
Yes.
they have to
Yeah.
keep, poo-pooing it and batting it away when people try to just point out to them what they just accomplished.
Yeah. 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 And right. And they're regulating expectations doing that too. Yeah. Absolutely. You know, every once in a while, we get parents of young adults in our program are just delightful people who just adore their kids, just love their kids, and aren't great parents. And some of them even sort of hand their kids to us for us to kind of reparent the kid a bit. And there's one way of looking at it and saying they're not being responsible. They should be doing this themselves. And there's another way of looking at it and saying, God bless them. They really love this kid and they kind of know they're not good at this.
Yeah,
But it's as much love as a good parent. It's
right.
the love is the same. It's just they're not good at it. What are we gonna say? I'm sorry, Tim.
And the willingness to acknowledge their deficit in that area and
Yeah,
try to find a way to get the kid, their own child, the help they need. That's altruistic.
yeah,
That's not
exactly.
abdicating, parenting authority. That's finding good solutions to a difficult problem.
Yeah, yeah. Our love for other people has to travel through our screwed up characters, get to their screwed up character, then travel through their screwed up character to get to their heart. By the time it gets there, it can be unrecognizable as love. It's been so perturbed along the way, but it
Well,
doesn't mean it's not love. It's just been
well,
shifted and changed.
and the filters that goes, it has to go through.
Yeah, yeah.
What's when people talk about the five love languages, and one of the biggest
Hmm.
problems with that is I keep sending out to my partner what I
Hmm.
want to get back, and it may
Hmm.
not be what my partner's looking for.
Yeah, that's right. That's right. Yeah. I forgot who called them idioms, but I like that idea. There's these idioms of how we interact, and they can not agree with each other, and they can seem offensive. And yeah, it's
Well,
this
so
element. Yeah, yeah, go ahead.
let's get a little bit refocused here, because I get the sense we could talk for a few hours and we've only got another 15 minutes or so. And
Mhm.
I've been through your book, Purple Crayon, and
Mhm.
I'm more than halfway through the book, How We Change and 10 Ways We Don't. Let me ask you to get yourself centered and say, if you only had, 10 or 15 minutes to drop some pearls for this audience, what would you want to get focused on and start telling us that you've learned that is so effective, or critical to people building that kind of life that you were referring to in the beginning?
Yeah, yeah, yeah. I think we have to find ways to recognize the other, that therapy and helping people change really has to do with this combination of care and recognition. It's what parents are doing with their infants. That when you're caring for the infant, you're simultaneously recognizing them. There's no language at that point. So every move you take to make sure they're okay is an act of saying, I see you. And every act of I see you in adulthood, when it's done right, is an act of care. And the thing that gets in the way of that process of recognizing and in caring for a person is another way of thinking, which is, I've got you figured out. Certainty, the certainty of, I know what's wrong with you, disrupts the process of being able to do what's called holding another. Make the person feel like they're held within your consciousness and your care. And so, and yet our brains are always looking to be certain. And so we have to really work hard to kind of keep that out of the way so that we can be in that state of recognition and care all the time, and to stay curious about the other, to always be in that state of curiosity. And I think that is really what helps people change, is I'm in the presence of somebody where they're witnessing me. They're a witness to my being. They're a witness to who I am. And our field has lost hold of that on some level. It's much more about, here's what you've got and here's how we fix it. I don't think that works. I really don't. I don't, it can be called the best practice if you want to call it that, but most of it is branding, most of it is sales. What we do know through years of research is what's called common factors. The thing that happens in every therapy that's actually working is the same thing, which is, did you build a warm collaborative relationship with the person? And for me, that's about, did you build a relationship where the person feels recognized in who they are? The, the, the Zulu people have the most profoundly beautiful way of saying hello. They say, I see you. And the response back is, I'm here. Our interactions where we're helping people should all be about, I see you and I'm here. You're found. I found you. Not I found you and I figured you out, but you can feel a little found here, found but protected. And
I keep coming
yeah,
to the issue of the brain studies they've done where they've mapped the brain and they've asked people, okay, what might this be? Like I've got something in my pocket. What might it be? And the brain lights up with activity as they're trying to
yeah,
figure out and this curiosity state is there. But as
yeah,
soon as the object is revealed, it all quiets down.
yeah,
And so
yeah.
if we can stay in that open questioning,
Hmm.
I'm here, I'm seeing you, and I'm curious about what it's like from your perspective, what's your experience of. If I can stay in that state, then I'm so much more engaged than when I think I
Hmm.
have you figured out and I sit back and
Yeah, yeah. That's exactly right. And what's amazing is it takes a lot of discipline to do that because curiosity's job is to finally figure things out. So you gotta stop it doing its job. You gotta say like, okay, look, curiosity, we're not gonna get to that place. I'm gonna keep you going without ever figuring it out.
yeah.
And that takes some work, takes some resistance on our part to hold back from this, oh, now I figured it out part. And then to kind of figure things out, to hold things lightly, you know. Um, it's an art, like art. Art's
Yeah.
never saying this is the truth. It's saying there's truth in the beauty of this, not this is a observable truth.
Yeah. And well, the poet Rilke calls us to learn to live in that questioning state and
That's great.
understand that in the moment that a mind asks a really good question, that particular mind isn't capable of comprehending the full answer. It needs to live along and grow and expand into the full answer to a really good
Yeah,
question. So it's
yeah.
that's art you're talking about of living in that questioning state without demanding an answer.
Right, right. And yeah, that's exactly right. And that's really where my mind is the last few years, is a little less on these social things and on what it means to be in a state of play, because that's what we're describing. A state of play is where um, something that feels solid is actually something that you are making something out of. It becomes yours, becomes something that belongs to you. And then you feel alive and it feels alive to you. And life comes out and everything feels alive. And that's really where we should be heading, is these states of play, not fun play, but the play of questioning, the play of curiosity and imagination. Those are actually resistant revolutionary ways to be, not just having fun on the weekend.
Well, and there are people who are exploring how the anxiety state that so many of us experience is incompatible with the creativity state. And
Right.
so they're actually exploring ways to help people into that creativity state as an antidote to the anxiety.
That's great. I didn't know about that, but that's great. That's what we need in this world. Yeah, yeah. There's this thing called mentalization, which is the capacity to understand the intent, emotions, and experience of another. It's kind of central to us getting along. The highest form of mentalization is to understand what another person, it's to hold a person's mind that's holding you. Who am I to that person? Requires such mental energy, but it's the ultimate mentalizing state. Mentalizing yourself in the mind of another. You can't do that when you're anxious. And it's a very creative event. Mentalizing is a creative event. It's really what you're doing when you make art is, what is this thing outside of me? How do I make it part of me? How do I understand it? What is it? And it's what you're doing when you're playing with toys. Is I'm putting life into this toy and I'm seeing this life in a toy. It's all those sorts of things. And anxiety and stress remove us from that, you know?
So what was the the big push to get you to write Purple Crayon?
Well, I did have some of this is using the Harold and the Purple Crayon book to talk about play in our lives and living a life as art. And I had some of that in How We Change. And then I began to look at the Harold book again and realize there's so much in there that I wanted to talk about. And I guess in some ways, it was my chance to talk about the people that informed me, which were the thinkers in the mid 1950s that were kind of, you could call them Marxist humanists. But there are people like Eric Fromm, Rollo May, not exactly a Marxist, but Rollo May, a lot of the kind of thinkers at that time. Also, just the great people from jazz who were kind of giving us an idea of how to live a life. And here's this book in 1955, the year where Martin Luther King, where the Montgomery bus boycott happened, and Martin Luther King was sort of catapulted into fame, who talked about the sacredness of human personality. And so I was interested about this time where people were really terrified of this strange thing they called conformity and what it does to our souls to try to be like everybody else. And the thingification of people that goes along with conformity. You're a this, you're a that, the dehumanization, which is really what King was fighting against in some ways, in a lot of ways. He was really talking about how do you make people into its, not human beings. And so Harold, in a strange way, gave me the opportunity for that. It came out in 1955, the same year as the bus boycott, same year that Allen Ginsberg read Howl, same year that Disneyland opened its gates, which basically commodifies the imagination, same year that Coke started getting distributed in cans so that one flavor could be around the country, same year that McDonald's opened. All this conformity was happening, and then there's all this revolt, all these interesting things in the arts happening. And that has an American story to it because there's these people called the Transcendentalists in Concord, Massachusetts, back in the early 1800s that were talking about the same thing. How do we live a celebrated life as individuals, not rugged individualism, but playful individualism? And how do we get closer to God, actually, through making sacred our own individuality? And Harold gave me the opportunity to do that. It really tells that story in a great way. It's this kid who designs his own life, and what he's designing is life, his own life and the life of things around him. So that's what got me turned on to it. It was really, really fun to write. It was really my favorite book that I've written.
Great answer.
Yeah,
Thank you.
Yeah.
Well, so I know we're running out of time here, and I'm just so appreciative of the work you're doing for. You've got the Ellenhorn centers in 3 locations.
Yeah. Yep.
Can you name them for us, please?
Yeah, sure. And just to tell you, we are the most robust community integration program in the United States, meaning we are really a hospital without walls. We're not just, a visitor person once a day. It really is the idea that the community is the place where you're getting your treatment. And then we're in LA and New York and Boston.
Yeah, I'm encouraging people. We'll have all of this stuff attached to the podcast, the website. It's all ellenhorn.com, etc. But I'm encouraging people to check this out because this is so dramatically different than a standard in-hospital stay or intensive outpatient, etc. So, and I'm anxious for the next book you might write that I can absorb. So thank you so much for your work and for taking the time to talk to us today. It's been a great pleasure.
It's been really great. You're good at this, and it was really great being interviewed by you. It really was. It was really fun to do it. Brightened my day.
From you, it's a high compliment. So have a wonderful evening, and thanks so much for taking time.
Thank you.
Ross Ellenhorn, PhD, is an eminent thought leader on innovative methods and programs which are aimed at helping individuals who have been diagnosed with psychiatric and substance use issues and helping them recover in their own communities instead of in hospital or residential settings. He is the founder, owner, and CEO of Ellenhorn. This is the most robust community integration program in the United States, with offices in Boston, New York City, and Raleigh-Durham, North Carolina. Dr. Ellenhorn is also the co-founder and president of the Association for Community Integration Programs and the founder of 2 lecture series that aim to shift current behavioral health paradigms. He gives talks and seminars throughout the country and is an in-demand consultant to mental health agencies, psychiatric hospitals, and addiction programs in the United States and Europe. Dr. Ellenhorn is the first person to receive a joint PhD from Brandeis University's Florence Heller School for Social Welfare Policy and Management and the Brandeis Department of Sociology.
You've been listening to the On Your Mind podcast, offered by Journey's Dream, where we support people through mental health challenges to a place of true and lasting well-being. If you love our show, we invite you to visit onyourmindpodcast.org to join the conversation, access the show notes, and discover our helpful resources. Thank you for listening.